but due to lack of real-time dynamic capability, it is not routinely indicated. Ultrasound is competing MRI for the evaluation of the abnormalities of Achilles tendon because of its real-time dynamic examination and its interactive facility. That is, when you place the probe, you can point out the painful area and you can concentrate more on that area. So regarding the general principles, it is very important that you must select a proper equipment. An ultrasound machine with a 7 to 12 megahertz pulse is usually used for the musculoskeletal imaging. But in case of Achilles tendon, it's better. We have found a better results with the 10 megahertz probes. Proper positioning of the patient is also very important, and thirdly, the sonographic technique. So, as I mentioned, that a high resolution equipment with a linear transducer is very, very important. So the routine examination is performed while the patient is put in prone position with the feet hanging over the edge of the examination table. The transducer is placed directly on the skin with an acoustic coupling gel. And while doing the ultrasound examination, it is very important that the ultrasound beam should be perpendicular to the tendon structure. Otherwise, it may give the artifact, that is the anisotropic effect, and tendon may appear dark. The scanning is first started in the longitudinal plane. You can start either from its musculotendinous junction downwards or from the calcaneal bone to upward. During examination, the dorsiflexion of the tendon, dorsiflexion of the foot helps to stretch the tendon and keeps it straight. In cases of rupture of the tendon, the dorsi and plantar flexion, that maneuver makes the examiner to observe the distance between the rechecked tendon edges and a distance in between them. The retrocalcaneal bursa is realized where the tendon is inserted onto the calcaneal bone, and normally it is less than 2.5 millimeters. So if the fluid or if thickness is more than 3 millimeters, it is pathological. That's how we place the probe, the transducer, to start the examination. It's better to use a small footprint, and it's easy to handle and gives a good view. After the longitudinal scanning, the probe is placed transversely, and in transverse plane we see that the tendon attains a elliptical shape. The structures other than the tendon which we see during the examination of Achilles tendon is the Cager's fat pad, the flexor hallucis longus muscle, and the posterior ankle joint recess. It is how to place the transducer transversely. Now, fortunately, musculoskeletal ultrasound is able to recognize quite easily the various types of the tissues under examination. We can recognize the macrostructure of various tissues. The tendons, they appear fibrillar with hypoacric collagen fibers. and hyperechoic endotendinal septa that are intermingled with them. In longitudinal scanning, we see the parallel hyperechoic and hypoechoic lines, while on transverse scanning it appears oval shaped. That's how a tendon on ultrasound looks. The normal structure of the Achilles tendon is insertion onto the posterior aspect of the calcaneal bone, and it is just deep to the skin and subcutaneous tissues. In between the tendon and the calcaneal bone is the bursa, that is retrocalcaneal bursa. There is another bursa that is called situated in between the skin and the tendon, but normally we don't see that. In pathological conditions we can see the fluid collection in between the skin and the tendon structure. Another view of the normal tendon. In longitudinal scanning we see the hyperechoic and hypoechoic lines running straight, and it's a fibrillar pattern, while in case of transverse scanning we see the ovoid shape and these round to oval shaped hyperechoic structures. Those are the endotendinal septa. Another beautiful view of the normal tendon. It's a split screen image. The longitudinally placed collagen fiber and endotendinal septa giving this fibrillar pattern to this tendon. So the tendon abnormalities which we can detect on ultrasound examination are the tendonitis, the rupture, the bursitis, and xanthomas in familial hypercholesterolemia. The tendon responds to various physiological activities by inflammation or degeneration, and the repetitive microtrauma may result into micro ruptures, and if it is beyond the physiological threshold, that may cause a rupture. But even in the limit of physiological threshold, if there is no time for the repair, that may give rise to a tendon rupture. So tendonitis can be acute, chronic, and rupture it can be partial or complete. And in case of bursitis, we see that the bursal inflammation, either it is retrocalcaneal bursa or the other one situated just deep to the skin. In acute tendonitis, we see that the tendon is swollen and it is hypoechoic as compared to the normal tendon. But the criteria for the diagnosis of acute tendonitis is a difference of more than 2 millimeters between the AP diameters of the tendon, between two sides, the normal and abnormal side. While in case of chronic tendonitis, we said that there is a heterogeneous pattern and the tendon is thickened. It may be associated with or without, may be associated with calcification or without calcification. Just yes. This is acute tendonitis. We see that the tendon is inflamed, and there is more posteriorly it is showing a hypoechoic area. There is a relative sparing of the anterior fibers. The same tendon on the transverse scanning. No, here it is the pathological acute tendonitis, while this is a normal tendon. So you can see, you can compare the difference on the two sides. That here we see the normal fibrillar pattern, but on this side there is the the space in between these longitudinal fibrilla is increased, and overall the echogenicity is decreased. The same pattern on transfer scanning. Another sonogram of acute tendonitis. Here we see that there is a focal area of inflammation, and at this site the tendon diameter, epidiameter, is increased. This is a sonogram of the chronic calcific tendonitis. We see the tendon has lost its normal pattern and it is heterogeneous, which with the areas of these calcifications. Those appear hyperepic on this scan. Although it's not a good picture, but we can appreciate that this is the calcaneus bone, this is the tendon, and this area totally anechoic. It is the fluid collection representing the retrocalcaneal bursitis. Now the tendon rupture, it can be partial or complete. In the partial rupture, there appears an intrasubstance hypoechoic foci that is filled with the normal fluid that may be associated or without tendon thickening. So it's not necessary that tendon is thickened. It may be without the thickening of a tendon. But we see the hypoechoic areas. It can be intrasubstance or on either side. And in complete rupture, we see that there is a complete discontinuity of the tendon. So the gap in between the retracted tendon edges can be filled with the granulation tissue and herniated cages fat. So now this sonogram shows that this is a longitudinal one. Here we see the tendon structure, but at this part there is the herniation of the cages fat and there is no tendon structure. The same on the transverse view, that there is no, we cannot appreciate here the tendon structures, only this herniated fat is seen. This is a partial tear. We see that is a hypoechoic area in between the tendon substance. The same on transverse view. Another case of partial tear, we see there is a small hypoechoic area, longitudinal area. It's almost complete. And the message in the end is that compared to the magnetic resonance imaging, which is static, ultrasound has the capability of demonstrating physiological movements and is simpler and more cost effective. So the clinicians encountering pain in the HD's area should not be content with the conventional radiography and the clinical examination alone. They should be encouraged to include the ultrasound examination in primary diagnostic protocols. Thank you.
Thank you very much, Dr. Shahid, and thank you very much for sticking to your 20 minutes. The next speaker is Dr. Zahid Pasha, who will be talking about fetal chromosomal abnormalities as seen on ultrasound. Dr. Zahid Pasha leads the science and art of ultrasound in Islamabad. He has trained at Johns Hopkins University, USA, and he has worked there as an instructor, and he has 1,000 notches on his dagger. He has trained 1,000 physicians in ultrasound in Pakistan. Dr. Zahid Pasha and his talk on chromosomal abnormalities, and you have 20 minutes, sir. You have a timer that is running on the top left corner of your screen, and I wouldn't want to interrupt you, but please try to stay within the allotted time. Thank you.
Thank you, Dr. Sabir. Role of ultrasound in fetal chromosomal abnormalities. Maternal age is important. The incidence of the chromosomal abnormalities increases with the maternal age, especially above 35 years of age. But not all the chromosomal abnormalities would be affected by the maternal age, like triploidy or sex chromosome abnormalities are not affected by